Hi everyone, I'm Brian Klein, a clinical nurse expert for the Medicine ICU at UK Healthcare. I'm doing a quick intro to this video because it contains a sensitive but very important subject, escalation of care. I'll introduce my colleague in a moment, but first, some quick disclaimers and disclosures. The contents of this presentation are intended to be used in the Medicine and Intensive Care Unit at the University of Kentucky Albert B. Chandler Hospital, or UK Healthcare. Always yield to your institution's policies and procedures. Observe all federal, state, and local laws. None of the speakers have any conflicts of interest to disclose. This presentation was scripted, captured, and edited without the use of artificial intelligence of any kind. Without further ado, I will present Lakin Keithley, my fellow clinical nurse expert. Enjoy the presentation, and feel free to watch at 1.5 or 2 times speed.
Welcome everyone to our first session of MICU Bytes, bite-sized education that you can stream. We will jump straight into our topic for the day, something that every nurse experiences at some point in their career, knowing when and how to escalate care. This can be one of the most uncomfortable parts of our job, especially when you're new or you feel like you have concerns and you're not being heard. And by the end of our session today, our hope is that we all feel a little more confident recognizing when a patient needs the extra attention and understand the resources that are available to help you advocate for your patients. Today, we are joined by some special guests. We have Adam and Jenny, our nurse manager and assistant care manager, here to help us with the nursing side of things. And we have Anastasia Klotz and Data Preet, a couple of our providers whom most of you have likely worked with by this point to help us understand the provider perspective of the escalation policy. So let's start by looking at a situation that might sound familiar to some of you. You are caring for a patient who suddenly develops labored breathing, they look pale, and their vital signs are starting to trend in the wrong direction. You reach out to the resident on call, but they don't come see the patient or seem maybe overly concerned over secure chat. So what do? Would you assume that you're overreacting and continue to monitor? Would you contact your charge nurse or maybe another senior nurse for an extra opinion? Or contact the fellow? So the reality is that we've all been in situations that sound just like this one. One of the most important lessons that experienced nurses learn is to trust their clinical judgment. And that doesn't mean necessarily that you're acting on your own, but that you recognize when something isn't right and you act on that gut feeling to get help. And at UK Healthcare, every nurse has both the authority and the responsibility to escalate care whenever there's a concern about a patient or their safety. And here's the thing, it's not optional. It's a part of our commitment to safe patient care under our nursing policy. And that policy is NU 01-05. We will go over that a little bit later in more detail. But we aren't going to pretend that escalating care up the chain isn't intimidating. And many of us who've been in your shoes worry that we're going to offend somebody or make it seem like we don't trust our provider's judgment. However, the important thing to remember is that escalation isn't personal. It's about the patient, their safety, and our duty to provide the best care that we can. As such, it's important to remember that our goal isn't to prove somebody wrong. It's to make sure our patients receive the care that they need as quickly as possible. And there's two important pathways to remember. We have the provider chain of command and the nursing chain of command. And knowing both gives you multiple avenues for getting the right kind of help when you need it. So now we're going to have Anastasia and Preet talk about escalation of care from the provider standpoint.
All right, guys. So our topic for today, we're going to be talking about escalation of care, which I think is something that we do every day for our patients, that you do as bedside nurses, advocating for a declining patient. But I want you guys to just be comfortable and familiar with escalating up the chain of command. That's not something that we necessarily do every single day. Sometimes when you're advocating for your patients, it might feel effortless. You might have multiple care providers at the patient's bedside intervening quickly. And then sometimes maybe not so easy. I think it's really important that you know that as nurses, you guys are the the boots on the ground. You guys are assessing the patients 4 times daily. And as you kind of notice differences in your patient's conditions or just small subtle changes that you guys feel comfortable, telling your provider any concerns that you have. So for escalation of care, there is a policy on CareWeb. It's very easy to find. If you go to CareWeb and just search policies and procedures, escalation of care is the first thing that comes up. So it is nursing policy number NU01-05. And the purpose tells us that nurses, when they believe medical attention is warranted to a declining patient, it is the nurse's responsibility to secure assistance for that patient. Or if there is a reason to question a written order or the care plan of a patient, we escalate that up. So escalation of care is going to look different, whether a patient is kind of on the floor or progressive care unit versus in the ICU. In the ICU, obviously, we're very close by, we're more involved, and so you're not necessarily going to have to escalate to rapid response, but we're going to go over the appropriate chain of command. If a patient in the unit, you feel as though they're declining and you reach out to a provider, if you do not get a timely response or they don't come to the bedside to assess the patient, we'll talk about how we can go about that. And so this policy will outline the appropriate escalation.
I will just add that our nurses are viewed and should always be viewed as patient advocates. So don't let anyone make you feel otherwise.
So this is kind of a big decision tree, but pretty much if the patient needs medical attention, we contact the provider. Did they come to the bedside and address the concerns? Yes, then we'll go on our merry way. If there's still concerns, then we're going to look at the left side of this decision tree is the medical escalation. We don't have chief residents in the ICU, so if you're not getting what you need from your resident, we're going to talk to the fellow if we're on one of the teaching teams to address our concerns. We can then escalate to the attending. And then if things are still kind of questionable, we can go up to the chief or the chief medical officer. The nursing escalation, I feel like if we're concerned about a patient's condition, that first and foremost, your charge nurse should be involved to help support you, or just someone who's has more experience. So if that's going to be a unit lead, if your patient care manager is around, everyone there is to support you in a deterioration situation where you feel like your patient's not getting the care that they need. And then from there, they can involve the HOA, DCN, CNE, etc. So some pearls for escalation of care is we need clear, concise communication using SBAR. When a patient is declining, we get those SOS messages where we know that we have to come to the bedside right away. Then we can talk in person. But if you're sending a message, if you have a patient who's relatively stable, I really want to emphasize the importance of using good SBAR communication. Sometimes we might get a message that just says blood pressure is soft with an isolated vital sign. And that really doesn't give me a good idea of what's going on with the patient. So including a cohesive set of vital signs and relevant clinical data, what has changed in your patient's presentation or their assessment findings that are making you worried? And then what did you do, to try and did we have a low blood pressure reading? Did we zero our arterial line or change our blood pressure cuff? Those types of things. If our patient is alert and oriented and nothing's really changed other than an isolated blood pressure, that is completely fine to talk over text. But I just want to emphasize the importance of good communication on the Epic chat. I think if a patient's truly declining, the provider needs to come to the bedside, right? That way we can have an in-person discussion about your concerns. And we want to know your point of view. We want to know what your clinical expertise is and what you think is going on with the patient. I was a bedside nurse, and I feel like they're the most valuable asset. And so I always take your all's point of view very seriously. And so come to the bedside for that in-person discussion. I would say as providers, we go through similar feelings if we're trying to escalate care to another consult service and they aren't doing the things that we think are appropriate for the patient. Just for example, we might consult the surgical team and they'll say no surgical intervention is warranted, very kind of vague in their note. And as a provider, that leaves me wondering, like, why? Why not? Why is this not appropriate for our patient? So it might be intimidating to ask the why, like, why do you feel like this is appropriate or not appropriate? But having that open dialogue definitely makes you kind of understand both sides of the picture. So do not be afraid to ask why if you're unclear of like why we're doing something or why we aren't doing something.
If I may just add, asking that why sometimes is intimidating. So phrasing it in a way that you feel is more comfortable to you, you can just say, hey, for my educational purposes, I just want to understand why you made that decision or why you're not making that decision. Can you explain how you came to this decision, or what's the background on how you got to this decision? So sometimes I know, especially our newer nursing staff, just asking that why upfront is it makes you nervous, and that's okay. There are just, you can ask it in a way that makes you feel comfortable. But always, always, always ask the question, have the conversation, have the discussion, and don't hesitate to ask the provider to come to the bedside. They should be coming to the bedside. And if they're not, then you can ask them. It is in your realm of responsibility to ask that question to them to come to the bedside.
And if they don't answer your question, that is not appropriate. So that would be the time to escalate and get some additional bodies involved. Be prepared with your patients. Day shift and night shift, all providers should be rounding on their patients. Sometimes the start of days or nights can be kind of busy, but they should be touching base with you at the beginning between the first, I would say 1 to 3 hours of your shift. And at that time, definitely address concerns early. You have that nursing gut intuition that if something doesn't feel right or doesn't look right, you may not be able to say exactly what it is right off the bat, but we have that nursing intuition. So address your concerns early and trust your gut. So new as of this month, July 2026, we have attendings in-house during night shift, which I think will be super beneficial in any types of concerns that have happened on night shift. Everyone knows nights can get a little bit crazy, right? There's one fellow, and that's when all craziness happens, is in the nightlife when resources are limited. And so there can be multiple declines kind of happening. So I think attendings, they are rounding on the sick patients with the providers. So that's a good time to kind of say, hey, this is what's going on. They're in close communication. But with that being said, we are a teaching hospital, right? So there is, the residents are the first call providers. And I just want to make sure that we don't go straight to the attending and overstep the fellow if they are available and present. If they are not, totally go ahead and get in touch with who you have to in an emergency. But I think attendings being present at night shift will be definitely super, super helpful in kind of addressing some of those concerns that nursing staff might have.
I will just add that recently the attendings were also right before coming to night shift, since we have a lot of newer attendings who hadn't covered night shift before, have been made aware that fellows are still going to be the team lead. So always, if you're not getting the answer from the resident reach out to the fellow first.
Are you aware of like any current like barriers to kind of escalation? Have you noticed it to be like with one specific thing, like getting procedures completed, or?
I think that for a lot of folks, one of the biggest barriers to escalation is they're afraid to hurt feelings. And having been in the medical field for almost 20 years, it's one of those things where feelings are great to have, but we need to make sure that we're always putting our patient's safety first. So I think that's the one I have witnessed a lot firsthand.
That's super valid. And whenever I have those feelings, I kind of step back and I think, what if this was my mom? Like, what if this was my dad? Like, do I care? Obviously, we have to be respectful, but like, this is your patient. This is somebody's mom and somebody's dad. So maybe someone might have hurt feelings, but at the end of the day, we're here for our patients, and we're all one cohesive team with patient outcomes being first and foremost. So I definitely understand that.
Never feel bad about listening to your gut and going with that. And in this discussion, listening to your gut and escalating if you feel like there's something that needs to be done or should be done. Because again, patients come first, our egos come way last.
Also important to remember that as a bedside nurse, you're responsible for typically 1 to 2 ICU patients, whereas your provider will probably be managing at least 8. So they don't have time to sit there and get their feelings too hurt about one particular patient.
And I will say we also have a lot of newer providers. So part of our responsibility is to teach, right? We're at a teaching hospital. So whether it's teaching our newer colleagues, whether it's teaching our peers in a different discipline, teaching is part of something that we have to do. And sometimes you all can teach us your perspective about why you're worried, and we can teach you our perspective about why we are not perhaps as worried, or perhaps we are worried about something that maybe didn't seem like, something that you should be worried about. So that teaching perspective should be looked at from all different disciplines, from everybody's perspective, because we all can learn something from one another. Lakin, have you seen anything since the attending started at night? If there are particular things that are going well or not going well?
I think it's been going very well from what I can see. We still need to remember that they're there. As far as escalating care, I know we've had maybe 1 or 2 situations where we've maybe escalated to the resident and then didn't get an answer we were expecting, and then maybe kind of just let it go. And then sometimes gone to the fellow and then dropped it completely. So just getting used to their presence now is still a learning curve, but I think we're getting a little better, and it's been great having them there just for the procedural element of being able to get stuff done, getting lines in quicker and stuff like that. So
I will say, looking at the schedule for the year, most of our attendings who are doing nights are highly involved. Dr. Ballingy, Dr. Smith are doing, and Dr. Catherman are doing most of the nights. So they're heavily involved and want to be involved. So this should encourage our nursing colleagues to reach out if they do have concerns, or including them in those discussions, especially when they're rounding, because they do make it a point to round. It may be a brief, quick walk by, but that's the time to escalate concerns if it's early enough. And if it's not, they're there all night.
I do want to give Adam a chance to go over the nursing chain of command. All right, we have Adam and Jenny.
Yeah.
Hi, good morning.
So if you guys just want to take a minute and talk about things from your perspective, situations that you would like to see escalated better, or anything you guys would like to share.
Well, so I guess any issues that occur at bedside would ideally be escalated to the charge nurse, then to CNE, then to management, whether it's an assistant or whether it's at them, whoever's around or whoever you see. From there, it would go to Cortina, and then it would escalate further up towards Kim Blanton and then Gwen. So that would be your nursing escalation plan. As far as what we want to hear from the nursing staff, visitor problems that can't be dealt with between you and the charge nurse and the team, we're happy to help with that. Something I tell the clerks all the time is if you've got a family that is calling over and over again trying to get updates and the nurse is still busy because the patient's really sick, you can't leave your bedside all the time to take a phone call. To not just keep telling them, I'm sorry, I can't take the call. I'm sorry, I can't take the call. That needs to go to the charge nurse or to me. I'm happy to always talk to family. I'm very transparent with them that I'm not the bedside nurse and I'm just looking through the chart. But I answer their questions as best they can. They just want to talk to somebody. So that would really help prevent escalating that. Not being able to talk to somebody would prevent a lot of customer relation phone calls and just that poor experience of being a family member of a very sick patient. Other things, so we came in today and found out that someone had called the police for requested presence on a family family. I don't know if it's a family member. We don't really have any details, but we have no idea who called or why. The police don't even really know why they're here. We've not had problems with this family that we know of. So definitely if there's potential for violence going on, we have to know about that. We got to know the details.
I think the only thing that I would add to that is that the escalation is important for hierarchy and decision making, but for communication as well. So just, if you skip over a whole bunch of people and go straight to the CNO and don't involve Jenny or I or the charge, then none of us really know what's going on. So escalating up the tree is really important for the communication aspect of everything as well.
Using the chain of command is really good at letting the person that you eventually have to escalate to knowing what has already been done and what resources were available to that person. I think sometimes as a bedside nurse, you get it into your head that it's all about somebody's professional role and their title, and it like that's part of it, but it's definitely, as Adam said, a communication device that is essential.
So I think that's definitely a barrier with escalating to the provider standpoint. Some people are not approachable, whether they mean to or not. So I talked with this attending about it and just about, trying to be more approachable and that people do see him as dismissive sometimes. And it's harder for people to come talk to him about things. But at the same time, in this situation, the plan of care was pretty daggone clear. So I don't know. But for me, maybe I should have talked to him first anyway, but I definitely think it needed to be escalated, that it was a plan. So always ask, we're here.
No, I was just going to say, Virginia and I are always there in some shape or form, clinically, non-clinically, but we're around. And if you don't see us in person, reach out to us. We're always checking our emails and our phones constantly.
We want to thank all of our speakers for joining us today and giving us their perspective and some information. And our biggest takeaway that Brian and I want everybody to remember is that if something doesn't feel right, we want you guys to trust in your assessment and always ask for help. Just a reminder, escalation isn't about questioning somebody's expertise. It's about protecting you, your patient, and your colleagues. And we want to emphasize that you're not bothering anyone by advocating for your patient or their safety. So with that, we again thank you guys for joining us today or in the future. We will be announcing our next MICU Bytes session soon. It will likely be in October. We do not have the topic picked out yet, but we look forward to seeing you there.